So, good morning, everyone. At the very outset, I would like to thank Dr. Animesh and the entire team for giving me this wonderful opportunity to discuss about the management of end-to NSCLC. I am going to talk about a non-metastatic setting, and now end-to NSCLC is really complicated. So many options, so many molecules. So let's go one by one. And I think today I have all my panelists, like Dr. Shushmita is here, Dr. Puneet is here, Dr. Shubhadeep is not there. Okay. Then we have Konishko, Dr. Abha, and Devojyoti is there. Okay. And Dr. Sanjay. Okay. Dr. Saurav. Fine. Okay. So let's start. So is there any change in the nodal staging in latest AJCC? Any one of you? Yes, sir.
Yes, sir. There's N2 is divided is as N2A and N2B, depending on the station, whether it is single station involved or multi-station involved, because the resectability criteria will differ and the management will differ.
Sure. So if we see the change in AJCC 9, you will find that this is the N2A, single N2 station involvement ipsilateral, and N2B, it is multiple N2 station involvement ipsilateral. And if it goes to the contralateral side, then it becomes N3. M1C, 1 and 2, it is divided, but I am not going into the detail of that. So if you see the composite staging, then you will find that if it is a T1 disease and if it is N2A, then it is composite stage 2B. If it is N2B, then it straight becomes stage 3A. And if it is a T2 disease with N2A, it is 3A, N2B, it is 3B disease. And T3, again N2A, it is 3A, N2B, it is 3B, T4, it comes straight to 3B disease. So this is the composite stage grouping now. Now, if a patient has multi-station N2B disease on PET-CT, will you require EBUS for media channel staging? So we have with us radiation oncologists. Any of the radiation oncologists can tell us that whether you will go for that or not. Say, Dr. Kanishka.
Yes, I will definitely go forward with EBUS.
How it will help you? Why you are doing that? Whether it will help you in the radiation planning?
Definitely will help me in the radiation planning, and we definitely get a tissue diagnosis and get the exact staging.
So you have the primary sample is there. You can go for the biopsy, be it is adeno or squamous, whatever maybe. Now you have multi-station N2 disease. Then I am asking that. So EBUS is mandatory. You are saying that you routinely you go for EBUS.
Yes.
Anyone from the surgical side in the audience? From the mid-on?
I think even if it is not N2B, even if it is N2 non-bulky, I think EBUS is a way to go, because you prevent basically in the end thoracotomy when you're planning. Suppose, I mean, it's a non-bulky thing, you're going to operate N2, which is potentially resectable. I think EBUS gives a lot of freedom to the surgeon in the end to not do it.
So the consensus is that even it is a multi-station N2, then also we are going for EBUS for all the cases. Fine. Sweet. So this is a case, but I am not going for a case-based discussion. I will give you different kind of situations, and I will ask you what are the practices you follow. So it is a say left-sided NSCLC on PET-CT, MRI brain, no metastasis, biopsy. Think it is adenocarcinoma, PFT DLCO within normal limit. Will you go for molecular studies and PDL1 testing for all the cases? Any one of you from the Medong side or Redong side, anyone can take this question.
I'll do in all the cases.
Be it squamous also, you are going for all the cases. So which kind of molecular studies will you follow? You will go for EGFR Al cross, or you will go for a 52 gene panel, or the whole,
No, sir,
whole
EGFR Al
NGS?
cross is enough.
EGFR Al cross is enough?
And PDL1.
Okay, any difference in opinion from anyone? Okay.
Get everything. Why we need to restrict to only 3?
So that's my question. So Bhivasa, anything you want to say?
I prefer to include everything in all the cases of lung.
So for be it adeno squamous, you are going for the whole thing.
Full genomic test.
Okay. Dr. Bhivas?
I have my talk on this detail, but still the question is, as of now, we have the adjuvant or neoadjuvant only on EGFR ALK and PDL1. So I think EGFR ALK cross one will be the minimum. You can have NGS full panel. The question is, if let's say this patient comes as BRAF,
Yeah, so
What
that is
will-
the thing.
What
Yeah.
we'll do?
Yeah.
We don't have answer yet.
So routinely you are going for the whole NGS?
At least three, but if possible, yes, you can get the whole NGS. But sometimes it will confuse you if you get something beyond these three.
Okay. So this question to Dr. Roy Chaudhary, do you think EBUS is the optimal mediastinal staging procedure at the moment?
Yeah, I think one of the interventional procedures that has changed management and staging of lung cancer completely and relatively non-invasively is EBUS. Previously, you would have to send these patients for mediastinoscopy, admission, a proper surgery. And now in EBUS, we do it as a daycare procedure. And it definitely is an optimal mediastinal staging procedure. As Debopom showed before, that when you go through the bronchial tree, there are only certain stations you can go to. And they are 2, 4, 7, 10, and 11. It's usually 5, 8, and 9 that they say you can't access. But for a competent EBUS scopist, we put it through the esophagus and we are able to access those as well. So in about 95% of cases, if the node TBNA, EBUS TBNA is adequate. But if it is a hard node, then cryobiopsies can be helpful. Again, that can be done only if you are doing it through the bronchus and not through the esophagals. So EUS FNA doesn't help. EBUS FNA IB is quite helpful. So about 95%, I would say.
So even in 5 and 6, you will be able to access.
Yes. Through the EUS stage, through the esophagus.
So where you feel that anterior mediastinoscopy can be complementary to EBUS?
Yes. So anterior mediastinoscopy is complementary again in stages, in places where you can actually access even through the EBUS TBNA. So station 5 is difficult for them as well. It's not easy. So it's usually the EUS side that is easier to do it.
Okay. So it's the message to the hall that EBUS is now the optimal mediastinal.
You don't need a peak sample for EBUS because that molecular testing already has been done from the
So even 5 and 6 also you can access, and 8 and 9 you have other procedures also. So as far as pathology is concerned, I think no one is there from the pathology side in the panel, but we have Dr. Neeraj with us, and we will also like to take the opinion from the pulmonologist and other oncologists. EBUS samples are adequate for molecular classification and PDL1 testing. How you feel about that? But we have listened to the talk of Dr. Debopom, where he has mentioned that it is not yet validated for the PDL1, be it the FNA or the cryobiopsy. Yes, Dr. Bivas, anything you want to tell?
We have the data of PDL1 even on cytology now from the blueprint 1 and blueprint 2. So the sample adequacy is most important. If you are getting an adequate sample, every molecular testing can be done, and we have done it. I think Dr. Neeraj is there.
So it is said, like when in our clinical practice, we found that if it is a more than 20% cellularity,
That
you
will
can
be
go
enough.
for most of the molecular tests. But whatever the whether for PDL1 it is validated yet or not, I am not very sure. Please, I want to know your
In
opinion.
cytology, it is validated now.
Yeah. Can I add it?
Yeah, please.
So what he was trying to say was that cryobiopsy versus A hasn't been validated, but EBUS TBNA for PDL1 testing is validated. The only thing you need to tell your pathologist should be good. They should ask for most of the sample in the cell block specimen rather than on slide.
Yes.
What most pulmonologists do is send it on slides and send very little sample on the cell block. So cell block should be maximum, and that should be good enough.
Okay, thank you. So Dr. Neeraj, any kind? Oh, okay, sir, please.
Assessment of the PDL1 percentage, which is important in deciding the treatment, is difficult with EBS. But one thing which I wanted to tell you, if you take a biopsy from the main lesion and only prove that this is inward, there is the chance of discordance between the main lesion and the mediastinal node is very, very less. It is less than 8% or something. So we can do away. We can do away with the PDL1 and EGFR molecular testing in the mediastinal when we do it in the main tissue. So
No,
this
sir.
is not
Yeah,
necessary.
I agree with your point. I have put this question because many a times what happened that twice we have done biopsy came negative, or sometimes the lesion is such that our interventional radiologist could not access, then EBUS may be the only option. That's why I'm asking that whether it will give you the PDL1 status also along with the other molecular report. But there are studies which have shown, yes, there are guidelines for acquisition and preparation of conventional and endobronchial ultrasound guided TBNA, and it has shown that EBUS samples more than 95% it is successful for getting the molecular test. And this is the quality metrics of the EBUS, where they're saying that whether you are achieving for EGFR AL cross more than 95% with the EBA samples, and you will test your real world data also whether you are reaching that level or not. But madam is saying that yes, she's absolutely confident that EBAS will give this kind of yield. If operable primary lesion, both to the surgeons, no surgeon is how you are going to decide in MDT. For all our medical oncology colleagues and radiation oncology colleagues, please tell how will you discuss? So you have option of pre-op chemo, you have option of pre-op chemo IO followed by surgery, or CTRT followed by durvalumab depending on the response. So how you are going to discuss in MDT?
See, basically, we discuss in the MDT. It is a single station N2. If it is operable, always surgery is preferred. As in an MDT, that's what we discuss. Is a surgeon's call. Who sees potentially resectable. There are two things: operability and resectability. I think that should be very clear when you're deciding. Operability, non-operability will be based on multiple factors: patient-related, age, comorbidities. But if you look at resectability, it is basically on table, technically you're able to resect or not. So if that is the reason, I mean, if you can resect it, then obviously I would prefer surgery followed by adjuvant in such cases if it is a single station N2.
Followed by initially you will go for surgery.
So if it is a single station.
Okay.
If it is resectable, sir.
From the Medong side, any difference in opinion?
No, sir, I'll give some sort of preoperative chemoradiation, chemo plus immunotherapy. If it is then downstage the disease, then surgery will be better, sir.
So even now there is data from the 1B resectable disease where you are going for pre-op chemo immuno followed by surgery.
Yes, sir.
And from the Radong side, any opinion regarding you will jump into CTRT or you will go for the same kind of protocol like pre-op chemo immuno followed by surgery or after surgery itself?
If it is resectable disease, I will prefer for surgery.
Primary surgery. Okay. So if you see, this is the kind of data. This was published 3-4 years before Checkmate 816. It was pre-op chemo immuno trial. It was pre-op, but there are many trials where there is pre-op versus peri-op. But I'm just discussing about the pre-op chemo immuno. That is 3 cycle of chemotherapy along with the nivolumab. And after that, they went for surgery. And if you can see the results is excellent. And they are showing it is a 2-year around 80% versus 70%. If you see the 4-year data also, that is also more than 60%. So it's excellent data. And if you see this one, PFS is also fantastic. And this is our Pacific data. If you see the 2-year OS, it was 60% versus 50%. And again, in the PFS, there was benefit 45 versus 25. So it is a reasonably fantastic option where you are going for pre-op chemo immuno followed by surgery. But mind it, this disease should be resectable. It is not like that unresectable disease or potentially resectable disease, and you are trying and you are saying that after 4 cycle, I will assess that whether surgery can be done or not. Then it will be a massacre because you are going for inferior or suboptimal treatment. Chemo done. Now you are saying surgery is not possible. Then you are going for radiation. That is a sequential chemo radiation. Results are inferior as compared to concurrent chemo radiation. So from the very beginning, you have to be sure that it is resectable or not. If resectable, then go for this kind of approach. So how will you select which chemo immuno combination? You have multiple trials, AGN, Checkmate 816, Nadim, Keynote 671. How you are going to choose your chemo immuno combination?
Sir, most of the trial have shown similar EFS benefit, but only the Pembro data has OS benefit, sir.
But that is a perioperative chemo immuno.
Yes.
So you are going for perioperative chemo immuno now?
Compared to pre-op is better, sir. The PFS benefit is better.
Okay. So how many cycles of pre-op and how many cycles after surgery?
Sir, pre-op is 3 to 4 cycle. Usually 4 cycle you give, and then in the adjuvant setting, in the maintenance, I'll give 1 year of immunotherapy.
1 year of Pembro. This is the standard practice you are following.
Yes.
Dr. Bivas, anything you are doing, same thing you are following.
But sir, Nivo can also be given because the Nivo data has more path-CR rates, sir.
Okay. So what he's mentioning, it is absolutely correct. So if you see all these trials, Checkmate, Empowered, and then Nadim, and you have this Keynote 671. So Keynote, if we see the Keynote study 671, it has shown overall survival advantage in the 3-year, and it was hazard ratio was 0.72, and you can see the confidence interval also, which has shown overall survival benefit. Other all have shown PFS benefit, mainly be it a pre-op or peri-op chemoimmunotherapy. So what our medical oncologist is suggesting, he is going for perioperative chemoimmunotherapy and surgery. So if it is a multi-station N2 disease, any role of surgery or CTRT is the only choice. So any of the radiation oncologists, can you please tell us?
I think if it is multi-station, I think it is CTRT. Surgery is ruled out anyway. I would not prefer surgery in such cases if it is a multi-station.
So you want to follow any criteria, performance status, nodal burden, extent of involvement, anything you want to look for?
Which huge disease stage and 3B, bulky disease, N2.
So multi-station N2, all we are going for CTRT from the Medong side, similar opinion?
Yes, sir. CTRT, sir.
CTRT. Dr. Bivas?
So first of all, I completely disagree that all multi-station should go for CTRT. If you see the all perioperative and neoadjuvant trial, 47% patient has multi-station. Among them, there is risk. So the question is whether this multi-station is resectable, bulky, invasive. Anything non-invasive, non-bulky up to 2.5 centimeter, they are resectable. All the trial, they included at least 30% has multi-station N2. And if you see the subgroup analysis from the meta-analysis, the stage 3 disease, including multi-station N2, got the maximum benefit from the perioperative chemoimmunotherapy. So invasive one, CTRT followed by Pacific, but resectable multi-station N2, definitely I'll go for chemoimmunotherapy. Now the question is how many station? So we take as multi-station at least if less than 3, then they should go for perioperative. If there is more than 3, I think the subgroup analysis will be discussed in the coming ASCO. So as of now, resectable multi-station non-invasive N2, my approach is perioperative chemoimmuno.
So there is a paradigm shift. Previously, it was like if it is a multi-station N2 or N3 disease, we usually go for CTRT followed by response assessment, and then we decide durvalumab. But if you see what Dr. Bivas is saying, I am absolutely agreeable with that. See there, it is a perioperative chemoimmunotherapy, nivolumab in resectable lung cancer, and you can see here, single station it was 59 patients and multi-station N2 31 patients. So it is around 13 to 15% patient had a multi-station N2 disease even in this trial. If you see this one, Nadim, this is a perioperative. Here also you can see that N2 multi-station, 22 patients in the chemoimmuno arm, and in the chemo arm it was 11 patients. So it is not only single station, multi-station N2 were also involved in these trials. If you see the resectability, it is in the center of debate. And if you see if it is a T4, if it is a T4 bulky disease, what he's saying that more than 3 centimeter or say 3 or more stations involved, then obviously you go for CTRT, it becomes unresectable. But if the limited stations are involved, it is non-bulky, multi-station, still you can go for a periop chemoimmuno followed by surgery. So this is the consensus guideline from the thoracic surgeons. And here we can see it is not the only multi-station N2, does not mean that it is unresectable. You have to select the criteria. What are the criteria for resectability? And according to that, you will decide. So multi-station N2, will you prefer pre-op chemoimmuno or peri-op chemoimmuno? Already we got the answer. Same kind of protocol we are following. Peri-op chemoimmuno, that is with pembrolizumab, because it has shown overall survival advantage. How long? He mentioned already it is 1 year, around 1 year. So I will, anybody from the thoracic surgery side? No one. So I was supposed to ask, what are the surgical difficulties or ease after chemoimmunotherapy? Because if we see the trials, we have seen in these trials that there was not much difference in terms of surgical complications in chemoimmuno versus chemotherapy arm. But I want to know the real world scenario, what the surgeons are facing. Unfortunately, we don't have surgeons with us, but any feedback from the audience?
So whatever we have, you are a part of the AGN trial. So whatever we have heard from Dr. Robin, our thoracic surgeon, that surgery sometimes become difficult, especially the nodal clearance. That is the only feedback I got from him. But out of this 15 patient, 12 underwent surgery, I think 1 patient has post-op complication, but the rest 11 did well.
So in the data also we have found,
Yes.
and in Tata also we have found 1 patient had severe complications after the pre-op chemoimmuno. So this was the peri-op versus pre-op comparison, that is checkmate 816 versus checkmate 770. It was presented in 2024. And it has shown that, again, peri-op has shown better results as compared to the pre-op one. So this is to the radiation oncologist. If pre-op chemoimmuno followed by surgery done, and if your margin comes positive in the final histopathology report, what is the role of radiation? Any one of it.
If this is an R1 resection, if the margin is positive, then definitely we will advise adjuvant radiotherapy, because that will help in the local control, which might translate into survival benefit as well. So if it is margin positive, radiation should be.
Have you got such kind of scenario in your practice? Why I'm asking, because this patient has already got chemo after that surgery done, and you are planning for post-op radiation, there will be higher chance of pulmonary complications. That's why I'm a bit concerned about it. That's why.
Theoretically, it should be prescribed.
So we had one patient who had R2. Actually, one of the lymph node was there that could not be removed. So the trial mandated that any patient who has R1 or R2 should be out of trial.
Yeah.
We have give radiation, but we are not given immunotherapy. So we do not know what will happen.
So we don't have any robust evidence for that. But obviously, technically, what you are saying it is correct. But we have to explain the pros and cons. What are the complications patient is going to face with radiotherapy that needs to be properly conveyed to the patient. So now I am coming to our zone, that is CTRT followed by durvalumab. This is all the trial, stage 3, concurrent chemo radiation followed by durva depending on the response. And anybody is different from this kind of protocol, 10 mg per kg 2 weekly versus 1500 mg 4 weekly. Anybody is practicing differently or same 10 mg per kg 2 weekly?
1500 4 weekly can also be given, sir.
Okay. So here it has already shown that overall survival benefit and PFS benefit already proven. So this is one important question: consolidation durvalumab for all comers or PDL1 TPS more than 1%? Practically, what you are doing?
Practically, as for the trial, it's for all comers, but the subgroup analysis shows that those who are negative, they have no benefit.
So practically, you are giving to the all comers?
No, sir, because the cost is an issue, so I'll prefer for PDL1 positive patients, sir.
Okay, so EGFR ALK negative and PDL1
positive.
TPS more than 1%, then you are going for the durvalumab. Anything you want to say?
But the trial, sir, they have included all patients, sir.
So if someone can afford,
but the
what will do?
On the subgroup analysis, they have shown.
So this you were mentioning that
yes,
it was a post-hoc analysis and it was an unplanned post-hoc analysis where TPS was less than 1%. Then it has not shown much benefit. But if you see the Pacific R data, that is the real world data, there it has also shown good results. But that's why I want to know, in real life, you are not giving if it is less than 1%. Dr. Bibas, you are doing the same thing?
No, we are giving to all.
You are giving to all. So there is no clear-cut consensus regarding this. So status of consolidation durvalumab in all other mutations like EGFR ALK negative, but any other mutation, you are giving or not giving?
Giving, sir, giving.
Same. So this was, I was mentioning, this was the Pacific R data. And here you have seen, I will show you that PDL1, when it is less than 1%, then also the results are quite good. Obviously, it is poorer than the TPS more than 1, but it has shown good results. This all you know. I think, what if N2 positive, EGFR positive adenocarcinoma, what after CTRT? So you are practicing osimertinib, started giving all these patients. But we don't have enough data for ALK positive or ROS positive patients, whether after CTRT we are going for any kind of alectinib or crizotinib, there is no evidence. But this is the standard trial which has come, which has shown PFS benefit. So this is to all my radiation oncology colleagues. Will you give stricter dose constraint for lung in CTRT followed by durvalumab thinking of radiation pneumonitis? If the patient has EGFR ALK negative and you are PDL1 TPS more than 1, you are planned for CTRT thinking that this patient might go for adjuvant durvalumab. And then whether you are giving stricter lung constraint?
In the original studies, the grade 3 to 4 radiation pneumonitis was not very high, I think around 3 to 4%. So I will not think of giving a stricter dose constraints.
Okay. Anyone different? So like a LRA principle, as low as possible, you are following like that?
Keep it as low as possible. I mean, the basic funda is, I mean, you're treating, it's the low dose which causes that. You look at V5 and we always look at V20 as a radiation oncologist. But if you look at the lower dose, lower spillage like V5, volume getting 5 grade, 10 grade, they're also like in the long run going to have problems with pneumonitis. So keep it as low. I mean, there's no cutoff. No one can say you wanted to restrict at 18 or 20 or 30, but as minimum as possible.
So usually we follow V20 less than 35 or V5 less than 70, V10 less than 50. And protocols have also followed the same thing, but there is one study from Japan where they are showing that this curve is little bit incorrect. I will say in the discussion they have written the right thing. If V20 was more than 18%, it has shown more complications as compared to less than 18%. So I think we should follow the LRA principle as low as possible. If you can keep, it will be better for your patients. And then comes, now the proton is there in India, 2 centers. One is Chennai Apollo and another is Actrec Mumbai, TMH. So any patient you feel as a radiation oncologist, which you will send for proton as compared to the IMRT, you will go for IMPT. Is there any subset of patients you feel?
See, again, there are a lot of retrospective trials done. There's no prospective evidence. No one has compared if you look at the data also. And again, the point is again the low dose. With the proton being delivered, your V5 and V10 becomes very low. But ultimately, you can't control V20. But there are few trials who have said the mean heart dose has reduced with the proton therapy compared to IMRT. If that benefit is there, I would prefer. But again, in India, again, the cost is a major issue where we're treating most of the centers have IMRTs and VMAT. IMPTs in 2 centers. Again, it becomes a logistically difficult for reason.
So you are right that in the protocols, it was mainly IMRT, cost is an issue, but if the patient can afford, if the node is too bulky, patient has interstitial lung disease where you can confirm your dose more, then proton can be one of the option, but in a very selected subset of patients, as a radiation oncologist, we should not indiscriminately use the proton therapy. It is for a very, very selected subgroup of patients. This should be the message to the hall. So there are studies which have shown, yes, lung and heart dose constraints, they could met better with the proton. I think thank you for your kind attention.
I have some question. Can I?
Yeah, please.
In a resectable lung cancer, in N2 resectable, we are using IO plus chemotherapy.
IO plus chemo.
IO plus chemo. Whether PDL1 testing is necessary before giving IO?
Even irrespective of the PDL1, if your EGFR ALK is negative, then you can go for a pre-op chemo IO or peri-op chemo IO. Not
EGFR ALK, if positive, then I can't go.
Obviously, no.
Oh, no. Okay. And another is, what is you have the multi-station, N2 multi-station. That is, one thing is, it is more than 3. And whether it is an invasiveness, whether we follow this 2 or if it is more than 2, if it is less than 3, then we can go for no invasiveness. Then we can go for operable.
Yeah. So if it is less than invasive, if it is less than 3 stations,
No,
if it is
less than 3, but invasive,
then you should not go for. Then
Yes.
it will be unresectable actually.
And if when we are using this IO, NSCT IO plus chemotherapy, whether the role of using adjuvant chemotherapy, adjuvant chemotherapy, and then followed by immunotherapy, is this any trial?
No, if you are planning for a peri-operative chemo IO, then you are going for already 4 cycle of
4 cycle, and then
you
after
have done
surgery,
surgery, then IO maintenance you will continue.
no role of any adjuvant. Okay, thank you.
I just want to make one quick comment because we are talking a lot about cancer, but PET positive N2 multi-station doesn't mean PET actually N2 multi-station positive, because more and more redo EBUSs that we are doing, we find that a lot of them have, in the Indian context, granulomas or TB in them, and they all come PET positive. So please, so it is absolutely make it mandatory, even if you find multinodal involvement, because in many cases, we have been downstaging these patients rather than upstaging them.
I have one question to Dr. Puneet. In that context, will the FAPI PET will be better useful than FDG if you're trying to rule out reactive or granulomatous?
FAPI PET will be not that useful. It has it will be more sensitive, but specificity is still.
And all my chairpersons.
Thank you, Dr. Tapesh, for such a marvelous panel discussion. May we have a group photograph?